Hi, it's Dr. Dave McCreary from POCUS UK, and in this short video I'm going to be showing you how to use point-of-care ultrasound to assess for a traumatic elbow effusion in a child. So if I was faced with a child with an undifferentiated elbow injury, the initial view that I would obtain would be at the olecranon fossa at the elbow. So for this, we can have the child positioned comfortably on the carer's lap. We don't need to move them in order to obtain this view, but we use the high-frequency probe placed posteriorly to the elbow, looking at the olecranon fossa. This is where any traumatic elbow effusion would be most evident, and in this transverse plane, the view we would obtain is one where we're looking directly through the condyles, and we're really looking into this fossa, which should normally be entirely shallow or empty. We can see a very, very small anechoic or hypoechoic region, which represents the just normal amounts of physiological fluid within the joint space. Whenever there's a traumatic effusion, we can see this region vastly increased. Now, this can either be a hypoechoic or anechoic appearance, or if the injury has been slightly older, so for example a child presenting after 6, 12 or even 24 hours, we can begin to see some changes in this area whereby the effusion content looks much brighter or hyperechoic. So if we were to show you how that looks in the normal and then contrast that to an abnormal appearance, we can clearly see here that what sits within the fossa is vastly elevated up and looks very bright, in this case echogenic, because again this was an older effusion. But we can see that we completely lose the margins of the condyles. We no longer see the olecranon fossa as a shallow region. We see it as one that's filled up with effusion effectively. In order to get a contrasting view in the long axis, all we do is simply rotate the probe 90 degrees. We try to stay within the midline so that we get a very on-axis view. And in this particular view, what we're looking for is the alignment of all of the structures superficial to the bone, so in other words the triceps muscle and the distal insertion of the triceps tendon, and then we see this very small region which is the posterior fat pad. Now the posterior fat pad is always there, it's always present. PEM trainees will be very familiar with this from interpreting lateral elbow x-rays, which is what we'll come on to. But when we're looking at in ultrasound, this region is in a position that's very constant and sits very flat, almost level with the bone within this fossa. Now, when a traumatic effusion has occurred, we can clearly see this be elevated by the hypo or anechoic fluid, or again can be itself bright if it's an older effusion, but this obscures the position of the fat pad and also of the triceps tendon and the muscle, so that things no longer run into a straight line. They're elevated upwards into a slightly more oblique pattern, which is something that would catch your eye fairly readily, and I feel it's something you won't miss if that was to be present. Comparing that to the features on x-ray, as we talked about, if we're looking at a lateral elbow x-ray, we know that the fat, which on x-ray isn't echogenic, it's actually dark because it's obviously a different imaging modality and doesn't look the same as on ultrasound, but it would become prominent. It catches your view because it's pushed backwards due to the effusion on x-ray and more visible for the x-ray beams that are going across, and that's why we see the shadow for a positive posterior fat pad. I guess my argument would be is that ultrasound is much, much easier to do. It's quick, it's repeatable, it's also really binary. So instead of arguing over whether there's the appearance of a definitive fat pad on x-ray, it's something that we can see really readily, easily on ultrasound. And here are just some cine loop examples where we can see the normal appearance, whereby the triceps tendon and all of the other structures running very, very straight and flat. But then with a traumatic elbow effusion, you can see that the echogenic fat has been elevated secondary to the effusion, and that the triceps insertion and structures are elevated so they don't sit very straight. So hopefully, using the views that we've shown you today, you could integrate POCUS into the assessment of a child with an undifferentiated upper limb injury. I hope the video has been useful. If there are any questions, feel free to message POCUS UK.